Hi, my name is Carolyn Becker, and I'm delighted to be here today. And thank you for tuning in to Intensive Review of Internal Medicine. And I'm the section chief of the endocrine section. And today I'm talking to you about take-home messages and clinical pearls of endocrinology. So these are my disclosures. I do write 2 chapters for UpToDate. So let's start with a case. Case 1, this is a 63-year-old woman who returns for management of type 2 diabetes, hypertension, coronary disease, CKD, chronic kidney disease, and osteoporosis. Her diabetic complications include nephropathy with a urinary albumin to creatinine ratio of 930 milligrams per gram of creatinine. She also has gastroparesis and non-proliferative retinopathy. Her meds include metformin, glipizide, and insulin glargine, as well as lisinopril, metoprolol, aspirin, and alendronate for the osteoporosis. Her most recent hemoglobin A1C is 8.5%, and her estimated GFR is 56 mils per minute. On exam, her blood pressure is good. She has retinopathy, clear lungs, no edema, good pulses, and a mild loss of sensation to monofilament bilaterally in her toes. So the first question for you is, what would you recommend now for management and improvement of her type 2 diabetes? A, would you add dulaglutide sub-Q weekly? That's Trulicity. B, would you add semaglutide, PO daily, that's called Rybelsus. C, would you add empagliflozin orally daily, that's Jardiance. D, would you add canagliflozin, PO daily, that's Invokana. Or E, would you continue her on her current regimen? I'll give you a moment or two to think. And I would recommend that the correct answer is C, that when you're intensifying this woman's diabetic treatment, the best choice of these would be empagliflozin. And why is that? So on this slide, I'm going to summarize for you the positive outcomes for these 2 big classes of drugs for type 2 diabetes, the SGLT2 inhibitors and the GLP-1 receptor agonists. And in the first column here, you can see that with the exception of stroke, which is in the purple here are the GLP-1 receptor agonists. Here, they are the only ones that lower the risk of stroke. But if you look at all-cause mortality, cardiovascular death, or reductions in 3-point major cardiac events, both groups of drugs, the red are the SGLT2 inhibitors and the purple, the GLP-1 receptor agonists. Both classes of drugs in major studies have reduced these outcomes. Now, if you look at congestive heart failure, only the SGLT2 inhibitors have a beneficial effect in terms of decreasing hospitalization and other good effects for congestive heart failure. But what we're really interested in is what do these drugs do for nephropathy? And here you can see that both classes decrease nephropathy. So how do we choose between them? Well, GLP-1 receptor agonists have very specific mechanisms of action, so it's useful to review these. GLP-1 is synthesized in the intestinal L cells in response to an oral glucose load, and in type 2 diabetes, GLP-1 is deficient. That's why we give an agonist, a receptor agonist, to boost and act like GLP-1. GLP-1 stimulates insulin secretion in the presence of an oral glucose load, yet it results in weight loss, unlike giving insulin alone. And GLP-1 reduces glucagon secretion, which is good, and slows gastric emptying. And that can be a problem for someone with diabetic gastroparesis. So in general, GLP-1 receptor agonists are not ideal in patients with gastroparesis. Now, if their gastroparesis is under control, you can consider them, but this should be considered a relative contraindication for patients with severe gastroparesis. Semaglutide, another GLP-1 receptor agonist, has another adverse side effect in addition to the GI effects, nausea, vomiting, diarrhea. Both oral and injectable semaglutide have been associated with higher rates of diabetic retinopathy. And as you remember, this patient has diabetic retinopathy, so you would want to avoid this choice if at all possible. If not, you need to monitor her very closely for progression of retinopathy. All right, so if we rule out the GLP-1 receptor agonists, how do we choose between the two SGLT2 inhibitors, empagliflozin and canagliflozin? How do we choose between them? Both of them are very effective for diabetic kidney disease. This shows the first trial in 2016, the EMPA-REG trial, in which empagliflozin slowed the progression of nephropathy in this large group of patients with type 2 diabetes who either had existing nephropathy or went on to develop nephropathy. And if you look at renal function in the EMPA-REG trial, you can see that in patients with GFRs above 60 and a similar pattern in those below 60 mils per minute, the empagliflozin led to an initial decrease in GFR followed by a stabilization and then a slow decline and another stabilization versus the placebo, which showed a very steady decline in GFR. So if we look at canagliflozin, this is the CREDENCE trial published last year, 4,400 patients with diabetes and albuminuria kidney disease, like our patient, on renin-angiotensin blockade, who were randomized to canagliflozin or placebo and followed for both renal and cardiovascular outcomes. They actually stopped the trial early because of the results. And what we saw was that canagliflozin, here in blue, reduced the relative risk of end-stage renal disease, doubling of creatinine, or death by 30%. This was a highly, highly significant composite result with a very strong significance shown here, very strong p-value. And similar to empagliflozin, the effects on baseline estimated GFR, there's an initial decrease, and then you can see a stabilization with a very slow decline of GFR compared to placebo. And finally, if you look at the urinary albumin to creatinine ratio, both start with about 900 milligrams per gram of creatinine, like our patient, and you can see again, very significant lowering of albuminuria in the canagliflozin group. So why not choose canagliflozin? Well, that's because of the results of the CANVAS trial shown here. And in this trial, which was published in 2018, there was a higher fracture risk with canagliflozin. This is the number of fractures, percent of patients with fractures in this trial, quite significant. And it turns out that only canagliflozin has been associated with this increased fracture risk in type 2 diabetes in this one trial. So the other SGLT2 inhibitors, Empagla and dapagliflozin, have not been associated with increased fractures, and numerous meta-analyses of the other inhibitors show no effects, negative effects on bone mineral density or on fractures, and no correlation or increased risk with these agents as a class. So if given a choice between these two drugs, I think empagliflozin offers the renal benefits without the possibility of fracture risk in a woman with known osteoporosis. Let's move to case 2. This is a 30-year-old woman presenting with mild fatigue, 5-pound weight gain, and occasional constipation. She's 2 months postpartum and plans to breastfeed for 1 year. Her only medication is a prenatal multivitamin. Family history is positive for hypothyroidism in her mother. On exam, she appears well, though tired. She's a new mom. Her weight is 130 pounds, BMI 22, pulse 70 irregular, and her thyroid gland is completely normal. But her labs, which you check because she's got a little weight gain, a little fatigue, shows a TSH of 30 with a normal free T4 of 1.2. What would you do next? A, order a radioiodine scan and uptake. B, begin levothyroxine 100 micrograms daily. C, ask her to return for a repeat TSH in 1 month. Or D, check antithyroid antibodies. And I'll give you a moment to think about it. So I would say the best answer is to ask her to return for a repeat TSH in 1 month. You certainly do not want to do a radioactive iodine scan and uptake. She's hypo, not hyperthyroid. She does not have thyrotoxicosis, which is when you do these scans. And certainly you don't want to give her radioactive material while she is lactating. In terms of treating her with 100 micrograms, that would be a perfect starting dose if she had overt or symptomatic hypothyroidism. Generally, we replace thyroid hormone at about 0.8 micrograms per pound, and that would be a good dose for her. However, she has a normal free T4 and minimal symptoms, no goiter, and we would call this subclinical hypothyroidism. So if you're going to treat her, you would be best to use a lower dose, perhaps 50 micrograms, 25 to 50 micrograms per day, because her free T4 is normal. Now, it turns out what is most likely is we're dealing with postpartum thyroiditis. And in this setting, with minimal symptoms, no goiter, and a normal free T4, this is the most likely diagnosis. And the important point here is that you don't have to always treat these patients despite the TSH of 30, because 50% of the time, these will completely resolve without therapy. It makes sense in this minimally symptomatic postpartum woman to repeat the TSH in a month and see where she's trending. You can always choose to treat her if she becomes more symptomatic, or if her numbers show she's trending to a more permanent hypo or overt hypothyroid state. Antithyroid antibodies can be present in both postpartum thyroiditis and classic Hashimoto's thyroiditis, so they don't help distinguish between the two. And I would not necessarily recommend getting them here. Just repeat the TSH. Okay, case 3. This is a true story. A 60-year-old woman is admitted for an emergency laparoscopic appendectomy because of ruptured appendix and does well during the surgery. However, over the next 48 hours, she experiences nausea, vomiting, and hypotension. She needs IV saline and pressors. Her medical history is positive for severe arthritis in her knees and hips, as well as spinal stenosis. And her only medication is naproxen. On review of systems, she had noted fatigue and decreased appetite over the past 2 months prior to surgery. No headaches, no visual changes were noted. On exam, she has generalized obesity, but she does have a round moon face, lightly pigmented stretch marks or striae on her abdominal flanks, and she has positive supraclavicular fat pads. Her labs at 8 a.m. show a serum sodium of 130 with a normal potassium of 3.8, serum cortisol of 1.8, and an undetectable ACTH. She undergoes a 250 microgram cortisone stimulation test IV, and her serum cortisol rises from less than 1 to 2.5 micrograms at 60 minutes. So the question now is, which of the following is the most likely cause of her clear adrenal insufficiency? A, bilateral adrenal hemorrhage. B, pituitary apoplexy. C, suppression of the HPA, hypothalamic pituitary adrenal axis, from exogenous glucocorticoids. Or D, autoimmune adrenal destruction from Addison's disease. Again, I'll give you a moment to make your choice. And the correct answer here is C, suppression of the HPA axis from exogenous glucocorticoids. So, first of all, adrenal hemorrhage or autoimmune Addison's disease, choice A and choice D, can be ruled out immediately because the ACTH in either case would be high in response to destruction of the adrenal glands themselves. So you can rule those choices out immediately. Pituitary apoplexy, choice B, is typically associated with a pre-existing pituitary adenoma, and these patients present with sudden severe headaches, cranial nerve dysfunction, and hypopit, often visual symptoms, etc. In acute apoplexy, however, giving exogenous ACTH in the cortisone stim test would still be normal, because remember, this is an acute apoplexy, and the adrenals would still be able to respond to exogenous ACTH. Hers did not. So the most likely thing in this patient, and this is indeed what she had, is withdrawal from exogenous glucocorticoids leading to adrenal crisis. She had received multiple injections of methylprednisolone into her spine for stenosis and her joints for arthritis over the past 15 months from different orthopedic surgeons, pain doctors, etc. She gradually actually became Cushingoid from the absorption of the steroids from these depot injections. Following her last injection 4 months earlier, she had actually gone through some steroid withdrawal, but very mild, and she really didn't crash until the onset of her appendectomy with emergency surgery and anesthesia, a stress that her adrenal glands could not respond to, and she became hypotensive and crashed. And this cessation of steroids 4 months ago left her with chronic tertiary adrenal insufficiency, which I'll go over with you now. So here are the 3 categories of adrenal insufficiency based on the diseased organ. Primary adrenal insufficiency is when the adrenal itself is diseased, infiltrated, or destroyed, such as Addison's disease, tumors, tuberculosis, malignancy, etc. In that case, both CRH and ACTH are high, but the adrenal cannot respond. In secondary adrenal insufficiency, the pituitary is the source of the destruction or the suppression. CRH is high, though we don't typically measure this. ACTH cannot respond, so that's low, and hence cortisol is very low. Tertiary, which is what happened here, is when the hypothalamus is suppressed, CRH goes down, ACTH goes down, and cortisol is low. So this is the most likely cause here. And I'm showing the list of secondary and tertiary adrenal insufficiency Pituitary causes would be the cause of secondary, with masses, infiltration, infection, infarction, trauma. But glucocorticoids can suppress both the pituitary and the hypothalamus, shown here, and can cause what we would call tertiary adrenal insufficiency, though we don't typically measure CRH. So that's what she had, and she needed steroids and did well with going back on steroids, and then a very, very slow taper. And finally, case 4. This is a 45-year-old pharmacist brought to the ER following a seizure at work. She has no history of diabetes or of seizures. Her glucose in the field by the EMS team is less than 50. And when she gets to the hospital, she's put on an IV glucose drip, yet still becomes unresponsive. During her unresponsive episode at the hospital, her labs show a glucose of 32, insulin of 15, C-peptide of 4.2, and a sulfonylurea screen, which is negative. So which of the following is the most likely diagnosis in this patient? A, insulinoma. B, surreptitious use of exogenous insulin. C, metformin overdose. Or D, adrenal insufficiency. Give you a moment. And the answer is A, insulinoma. So in the non-diabetic patient who presents with symptoms of low glucose, which can be sweating, nervousness, confusion, lethargy, seizures, coma, the labs to get when the patient is symptomatic and the glucose is low include, in addition to the glucose, an insulin level, C-peptide, sulfonylurea, and we also screen for the meglitinides, Prandin and others, as well as a cortisol. And to understand how this works, it's important to understand the metabolism of insulin. It starts as proinsulin in the pancreas beta cells, and then is cleaved into two sections. The alpha and beta chain come together with two disulfide bonds to form insulin, and the C-peptide, this connecting peptide between them, is released separately. So there's generally a one-to-one release of these two from the pancreas. So when the glucose is low, let's say less than 50, and the insulin is high, how do you know if this is an insulinoma, someone overdosing on a sulfonylurea, or someone taking insulin? And the key here is to measure the C-peptide. When the C-peptide is high and the sulfonylurea screen is negative, as in this patient, this is very consistent with an insulinoma. If the sulfonylurea screen is positive, that is consistent with an overdose of a sulfonylurea. But if the insulin is high and the C-peptide is low, this is someone you should be suspicious about taking insulin either surreptitiously on purpose or accidentally, or someone else is basically trying to kill them. So that is when the insulin is high. If the insulin is low, when the glucose is low, you look at hepatic failure, heart failure, kidney failure, sepsis, alcohol, or adrenal insufficiency, growth hormone deficiency, other hormonal deficiencies, etc. Okay, so that's it. I hope this has been a nice review of some clinical pearls and some extra, hopefully extra new material for you. I thank you for your attention. I wish you the best during the course, and may you all stay healthy and safe. Thank you very much.